number 12. A 61-year-old female who actually has had stable angina for many months. And if you see the risk factors, hypertension, hyperlipidemia, she had LV dysfunction actually. EF of 25. She was managed medically, and of course, with the low EF, it was always bothersome when she had a stress test, which showed anteroseptal ischemia with the apical scarring. So, to rule out any CAD, she was sent for cath. So, if you see here, this is where we see the RCA, small. This is the EF, anteroapex, almost looks significantly down. This is where the LAD lesion is. Circumflex is non-obstructive.
So the MRI was done by the clinician before the cath. Is that a correct statement?
No. So she had cath. No, she had cath, and then I felt manager medically still optimized her before it looked disproportionate. Mm-hmm. And I thought since the stress test showed it was all apical scar, manager medically, and then because she still continued to have angina, they did viability MRI. That was later on.
Now, with that MRI,
complete viability of LAD diagonal.
With that MRI and these beautiful distal targets, what about a surgical consult here?
Syntax very low though. Prox LAD, no calcium. I mean, mild calcium, I would say. Right?
Okay, let's ask the panelists. Yeah. We have Professor John Fox. Professor Fox, what do you think about these?
You know, I'm inclined to agree with Dr. Kinney, given the fact that the score is so low. You know, it really looks like it should expand well. So I would be inclined to just go ahead with PCI, but have a discussion. She took the patient off the table. She got her information, and have a discussion with the patient.
Okay, and Dr. Nicholson is not, or Duvuri?
Yeah, again, if you had the heart team discussion, initially this looked like this was probably non-ischemic cardiomyopathy, right, Anu? That's what you thought?
Yeah, exactly. I felt it was non-ischemic cardiomyopathy, disproportionate LAD diagonal lesion, EF 25 did not make sense. That's why we took her off the table. I said, manager medically. That's how then the referring cardiologist had to convince me by saying that no, that area is viable and she's having. I mean, if somebody, I know she has heart failure, but if somebody has ongoing angina, I think that is telling us that the myocardium is viable.
Yeah, I mean, now that you know what it is, you can do either way. But in this lab, this can be done safely, so it's reasonable.
I think in summary, 25% ejection fraction, and with a beautiful big vessels here, the possibility to have a very good result percutaneously is there. I think, nevertheless, I like to explore surgical revascularization with the heart team approach. But having said that, I think we should move on. Anybody can talk.
This is likely non-ischemic, right?
Well, Dr. Puskas already left the room, so.
Yeah.
So the OB dysfunction.
25% for us is usually a rejection from surgery.
Yeah. And other thing which you did not mention here, patient has a history of breast cancer.
Okay.
And had received chemotherapy, no radiation, but chemotherapy.
Is that the origin of her
So that could be the reason also her LV dysfunction is disproportionate.
No. Heart block. Call Mark Miller. Make it under.
So we just dilated. You see that it looks well. I think based on our app, we know the significant diagonal is a 3O vessel, 3-5 vessel LAD, osteal disease, long lesion of the side branch. Has to be a two-step strategy. Anybody else would have any other?
Excellent expansion. You see no calcium on fluoro, huh? No calcium.
There is a little bit on the lower surface, if you see that. See that?
Yeah, maybe, yeah.
I think that if you're thinking this is ischemic, not an ischemic cardiomyopathy, I think the anginal provoking lesion may be in that second diagonal lesion. So I think you have to try to cover that. So two-stent approach.
That's exactly what you're planning, Dr. Kinney? 7 French 2-stent mini crush or any other?
Yes, mini crush.
Okay.
Although you
You can start playing the steps again by the side.
maybe avoid the
People downloaded the new Bifurcate 3D app. Bifurcate 3D app where you can start seeing the animations.
Yeah, I'm not sure this is a true bifurcation, though, right? I mean, it's a separate lesion in the diagonal with a ectatic area proximal,
But ostial.
and not so much at the ostial.
But ostium is involved. 50% in the ostium and 80% further down. You have to cover both the
So there is an osteal disease, I agree, but the question if it's compromising from the hemodynamic or from the physiology. So fixing the proximal vessel and then doing FFR is not unreasonable to avoid another stent and to simplify the procedure.
Or just having done flow studies to begin with.
I think this is a good question if we believe that ostial diagonal is significant. And for, last case of the day, such a huge diagonal, I think the right way to go is to go ahead and stent. But that ostium may look like a slit. When you do IVUS or OCT, sometimes it's just like a negative remodel, and there's not much disease there. So the comments are very well taken.
Also, it's a little.
No, but other question is, it is also complicated by second lesion after the ostium.
Correct.
So if you do FFR now, it's not going to help us.
No, you have to fix first of all
Right,
the
Ron?
lesion. Yeah, I agree. You have to fix the lesion first and then do an OCT. And then do an FFR.
Yeah. So
We
the
are
whole
2.5
discussion.
to
Yeah. Okay.
So if you see what I did, there was a wire was entangled. So I pulled back the LED wire. The cutting balloon would not go. I pulled back the LED wire and recrossed. Now the cutting balloon went into the DAG. It's a 275.
Yeah.
Down. Wolverine.
And this you're making your way through, huh?
Yes.
This is another.
This is a
technique.
true lesion.
Yeah, this is another technique that Dr. Kinney likes to do. So she balloons proximal to the lesion, make her way through.
Down.
Many operators will want to go directly.
And remember the DK Crush 6, the V actually used to be good with do multiple FFR of the side branch and decide, and with a randomized trial, it didn't show difference. So kind of, we have gone away with that now. I mean, in our lab. I know, Ron, your opinion and of course the data, but key is that if you think it's a tight lesion, it's probably better off. It will take more time to not leave it, will look a little hazy, will look a slightly dissection. So just finish it by using two-stent approach. Guaranteed you will going to fix it.
Yeah, in principle, I agree with you because the stents are so good now, and with a good technique, it shouldn't be.
And what's for the diagonal? 15.
So was the comment of fixing the diagonal only, after the ostium and leave the ostium alone and then stent across and then that was for academic purposes or was a serious question?
We need to have some discussion. Because we have another 6 more minutes. We are ahead of the time. Any live symposium with 10 cases, we are ahead of time.
By the time we finish to deliberate, the stent will be in.
Exactly. Beautiful.
Yeah, I don't think it would change what I would do. I'm just pointing out that it's not critical.
Any crush or what? Okay.
Not cover. Maybe short, right?
Keep saying what you're doing. So
no, I'm just, give me a 275 18 for the side branch. Yeah. We are going 275 18 for the side branch, 35 18 for the main vessel. So, see the other case, I did not show the mini crush live. We did a step crush. So we are going to show you mini crush live right now. Can we have the animation by the side? Is the animation playing by the side?
Yes, it does.
Pedro, do you see it?
It is.
Okay.
Not yet.
It's up here.
They should be playing.
We see it on the side.
Animation.
Animation
app team is there. They are very up to date.
Wow, look at that beauty.
Yeah.
Colorful. So we're doing the mini crush. So you're stenting on the diag right now in the animation.
Yeah. We have the stent placement there. Then we have a stent placement in the main vessel. Deploy the side branch. Remove the
Yeah.
3518 for the main vessel. So we're going up with 3518 main vessel.
So any comments?
And how do you know, sir? Any other technique?
Good.
Good.
Wow.
Some die quickly. Okay, you're happy with the 1 millimeter sticking in the main vessel?
Yeah.
Okay, good. Go.
Seen it?
Yeah. I'm going to pull the LED stand back a little bit.
Stay
Yeah, good. Who has the side
This is
branch?
the side branch.
Okay, go up with the side branch.
Going up.
Yeah. This is a 27518. Go.
14.
14. Down. Go up again. Then we will take out the balloon. Down.
And the wire.
And the wire. But we say just give some dye, make sure we are okay. Looks good. Now take the wire out. Normally I would use the same wire. Let's see how it's behaving. LED is okay. Some
Yep.
dye. This comes
Yep.
from LED is good.
Yeah, we saw it just now.
Yeah. Okay, good. Go up.
Going up.
Yeah.
I always add one other step
Yes.
here. When I deploy the balloon in
Good.
the
2 balloon.
14.
when I deploy the stent in the
And bring
diagonal,
back it at the ostium and
Yeah.
open it a little more, right?
I
No,
post
when you do-
dilate with that same balloon as I come out a couple of millimeters. Then I pull it.
So you're doing
Ost-
like
ostium,
pot.
yeah.
You're doing like pot
Yeah,
within
opening
the.
it's the same. Exactly. So basically just bring it back. We
Okay,
do
ready?
quite a bit. Yeah. Good.
Good. Done. Now we recross kiss.
That what to our audience, what John is saying,
Yes.
that you bring back the same stent balloon, few millimeter, and go to 20 atmosphere. So ostium has been opened. You had a little part of the proximal, although you crushed a little bit of the existing balloon.
You have not deployed the main vessel stent. What are you potting?
No, means opening the ostium kind of. It's
I
a
don't know.
proximal ostial diagonal optimization.
But you're going to finish with
PO,
kissing balloon anyway.
Probably. Yeah.
That's a
POD.
new fielder.
A new fielder.
Yeah.
So kissing balloon and a pot or kissing balloon and
It
that's
is.
it?
Yeah.
We are
need to-
kissing balloon and done. If you want, we can, I think,
Image.
You know, the
You want
European
the
loves the
image?
pot.
Yeah,
They're
yeah.
using
I'm
the
not
pot.
a believer of pot in non-left main.
Get out this.
So what balloon are you gonna put on the diag?
I think a
2.5?
2.5.
12?
No, 2.5 should be able to go. 2.5 should be able to go.
Maybe, yeah.
Get a 2.512.
So the whole claim of the double crush is that
We'll start with a
the
2.0.
recrossing is much easier. That's the whole claim. And I was proving in the first decay crush. But
You know, this whole decay crush has to be revisited, I think, with another
I agree.
good study.
yeah.
My own experience in our lab, when we started to do the decay crush, we started to see a lot of restenosis. And we actually and we followed all the steps. So I always question this. I mean, we have to have another study to confirm.
I agree with you, Ron. I mean, we've gotten away from it. It used to be the primary thing, and it's the right answer for the board questions, but I don't think it really plays out the way we think it does.
I agree to Ron.
And I agree with both of you. I can tell you the same feeling here. We will use a decay crash maybe in about 25% of left main, and rest of them almost none. We do reverse crush because of radial sometimes, but we will go with the mini crush technique. And I think the decay crush is still more difficult to go through it. Higher restenosis at the ostium of the side branch. So
Exactly.
Anu, would you have any specific situation you'll use a decay compared to your mini crush?
No, I just showed them step crush.
Yeah. No, but any
Huh?
No,
situation,
decay
clinical
crush.
scenario, angiography.
No.
Yeah. I would say no. So
No.
from our point of view, we may do it just to show because the audience many times ask.
Means only reason is suppose you have a 6 branch, you decided you're going provisional, you
Yeah.
are going to have a 6 branch, and now the diagonal, compromises, and you want to stent it, you use the step crutch which we showed in the earlier case.
That's us. Actually, you know, I agree with you. Everyone said about the DK. Not only that, but the restenosis is very severe, right?
Very fast, and also fast.
Like subtotal
Get me a
restenosis.
275 high pressure balloon to the side branch.
Yeah, very common.
Okay.
So that's why, Mike, we don't use the same. I know, I mean, a lot of people are, but clearly maybe the Chinese arteries are a little different. But
Well, he's a good
we
friend
need
of
to
us,
do the
and maybe
trial.
that's
Remember,
like the
everybody
Chinese
keeps talking
virus.
about.
Yeah.
Or the
Yeah,
Chinese
we,
data.
We need to do a study of the DK crush out of China, Europe, America, India, and someplace. So key is that we need to duplicate or replicate the same data. And the other question is, I think the DK crush was that of the left main was to the wrong advantage. When do you have?
What's
You conventionally you
3-5?
decided on 44% time you put a second stent.
That's fine.
The trial
3-5.
became, in my opinion, is like
3 to
mute
5? Yeah, good.
That's fine.
with that. Once you put a bailout, when people ask about the bifurcation, do you put a 2 stent or 1 stent? I said that should not be the debate. Debate should be identify those 10, 20, 30% of cases where will you need 2 stent. And those cases go forward. Because if you decided you're going 1 stent, your chances of second stent in the side branch as a bailout should be less than 5%. That means otherwise you didn't think through the complexity of the lesion. So key is it's not a debate of 1 stent versus 2 stent. Debate should be what case you can come out with the 1 stent or 2 stent in the bifurcation lesion. So that should be the debate, basically, and that's what it is. Yeah.
I would just remind you that S.J. Park, when he started, he did only cross over the LAD and he didn't stented the circumflex. And he got away with very good results for a long period of time. And you know, and I know that we get a lot of cases for brachytherapy for instant restenosis of the circumflex. And there is no way, as Antonio said, the only way not to have a circumflex restenosis is not to have an angiogram. But when it's come to a left main, this osteal circumflex is really hard to
Bring the
treat.
diagonal back.
So we have to think 3 times before we do those 2 stents for the left main. If you don't need to, don't do that.
Other thing is, do we do the, means anchor in the,
Yeah.
good.
Maybe just dilate here first and the
Yeah,
other will
go.
go. Yeah. Okay, now just
16.
Pedro, the plan
down.
would be in next 2-3 minutes we'll end here. You start your lectures and we both will be coming. Hopefully no traffic. So we'll see you before we end. We definitely
Absolutely.
don't end it because we have the raffle for the people who still stood in this.
Yeah.
I want to do a quick IVS to show that without pot, that did we
Okay.
have a good, go.
Go. And then there is
Both
I
sides.
saw still the trial still has to be published in the Euro intervention of the routine use of pot in the non-left main, and the trials were negative.
Okay.
But
So
left main was
one-
like 10-12% in that.
Anu, there was 3, 5,
Not
and
you,
2,
not
7,
you,
5.
not you, not side branch. Yeah,
The-
275 to the side branch, 325 to the main vessel.
Yeah.
Good?
Yep.
Yeah. Main vessel. Okay, good. We'll do IVS of the main vessel.
And then we end
Yes.
right on the dot.
Yeah, let's see how it looks angiographically.
Okay, angiographically, can you take a picture?
Yeah.
Good. Go. Nice.
Good.
Okay, get the IVS quickly.
Okay.
And then we have to go rapidly there.
Now, the purpose to doing the IVUS here is to look at your carina or proximal dissections.
No. To prove that you don't need pot in non-left main.
But you already
Yeah.
did a part, no?
And people ask us,
No, I did not pot. Pot is different. You need a short balloon proximal to the bifurcation.
so key
That
is,
was just
we do a
kissing.
kissing balloon. So we
Yeah,
more
exactly,
on
kind
the
of.
kissing balloon rather than pot.
And they are a believer. The people of pot, repot, and recross. No, it's called
Pot.
pot, kiss, and repot.
Yeah.
Yeah. So they are a believer that if you kiss and did not pot, you will get a elliptical stent in the
So
proximal, which we were the first one to show with our OCT study that you will still have the vessel. The stent takes the shape of the vessel. not elliptical or circular.
Now, with that diameter distally is at least 4.0 there, huh?
4, yeah.
3.5.
That's okay. There is,
Yeah, it says negatively remodeled. See? It's interesting. Now you have put a position, you have the wire there.
wow.
Yeah. Wire. It's interesting how this segment was negatively remodeled. And now you see your prox LAD.
Well opposed. Yeah.
Yeah.
Yeah, and not
No
elliptical.
dissection, you know.
Done.
You're done.
And looks very good.
Okay. So having said this, we're gonna move on. This last
All
session.
right.
Thank you.
Fantastic. Thank you. Thank you. We'll see you shortly.